So right now, sitting quietly just behind your stomach is well, it's basically a biological munitions factory.
Yeah, that's actually a really good way to describe it.
Right. And it is incredibly efficient. I mean, it operates in the dark, constantly churning out these chemicals that are so corrosive, so unimaginably powerful that they can literally dissolve meat and fat into liquid within minutes.
Which, is terrifying, but you absolutely need this factory.
Hmm.
Without it, you couldn't digest a single meal you eat.
Exactly. And normally, these highly explosive chemicals, they're kept under heavy lock and key. They're packaged safely and shipped out to your intestines where they actually do their job.
Right, they have a very specific battlefield.
But today, we're going to look at what happens when those locks break. What happens when the assembly line malfunctions, the pressure builds, and this quiet, underappreciated organ decides to arm those chemical weapons while they're still inside the factory.
Yeah, it's a disaster. We're talking about the terrifying reality of an organ essentially eating itself alive.
Which is just wild to think about. And that is exactly our mission for this deep dive. We want to shortcut you to being incredibly well-informed on a condition called acute pancreatitis.
And there is a lot of ground to cover here.
So much ground. We've gathered this massive stack of source materials, clinical profiles, pathophysiology reports, standard diagnostic protocols. We're going to unpack exactly how this disease works.
Down to the microscopic level, right?
Right. From a single cellular error all the way up to a body-wide systemic crisis. And we're also going to put you right in the emergency room looking at how doctors basically have to play detective to stop this runaway train.
It really is detective work, yeah.
And to help us navigate and, synthesize all this dense medical data, I am thrilled to be joined by our resident expert. Welcome in.
Thanks so much. It's really a vital topic for us to explore today.
I agree.
Just to set the stakes right at the top for everyone listening, acute pancreatitis is not some rare, obscure illness that you only read about in medical textbooks.
Right, it's not some 1 in a million thing.
Not at all. It's actually the leading cause of hospitalization for gastrointestinal disease in the U.S.
Wow.
Yeah, we are talking about hundreds of thousands of people ending up in the hospital every year because this internal factory has just gone rogue.
Okay, so let's unpack this. Before we zoom in and look at the actual mechanics of how this organ attacks itself, I think we need to understand the sheer scale of the problem.
Yeah, epidemiology.
Right.
Yeah.
Like, who is getting caught in this biological crossfire? And why is it happening more and more frequently? Because the numbers we're looking at in these reports are, frankly, staggering.
They're quite sobering, honestly. The data indicates that the incidence of acute pancreatitis is rising significantly.
Globally.
Globally, yes, and in the U.S. specifically. Right now, we're looking at an estimated 200,000 to 275,000 hospital admissions annually just in the United States.
That is a massive number of people.
It is. Now, medical statisticians, they always have to ask a foundational question when they see numbers like that. Is this a true, absolute increase in the disease burden, or have our medical systems just become much better at diagnosing it?
Right, like catching the milder cases that might have just been ignored in the past, the classic surveillance bias.
Exactly. If you look harder for something, you're going to find more of it.
So what's the verdict? Is it real?
The consensus among researchers leans heavily toward being a true increase, and it's largely driven by modern lifestyle factors.
I noticed that in the clinical profiles. They specifically highlight rising rates of obesity, metabolic syndrome, and let me make sure I say this right, hypertriglyceridemia.
You nailed it.
Let's break that last one down for the listener. Hypertriglyceridemia is essentially having an extremely high level of a certain type of fat, triglycerides, circulating in your blood, right?
Yes, triglycerides are a type of lipid, or fat. When you eat, your body converts any calories it doesn't need to use right away into triglycerides, and they're stored in your fat cells.
Makes sense.
But when the levels in your bloodstream become extraordinarily high, and we're talking usually well over 1,000 milligrams per deciliter, whereas normal is under 150.
Oh, wow. So nearly 10 times the normal amount.
At least, yeah. When it gets that high, those fat molecules can actually become toxic to the delicate tissue of the pancreas. We'll get into the exact cellular mechanisms in a bit, but high triglycerides alongside obesity and metabolic syndrome,
they're basically throwing fuel on the fire.
Precisely. They are recognized as major accelerating risk factors for this disease.
Okay, so the triggers are increasing, which explains those 275,000 admissions. But I want to make sure we don't paint this as an automatic death sentence for all of those people.
Oh, absolutely not.
Right, like if you or someone you love gets this diagnosis, what are we actually looking at? because the disease seems to exist on a remarkably wide spectrum.
It is a vast spectrum, which is one of the things that makes managing it so tricky for doctors. For about 80% of patients, they present with what is classified as mild disease.
Okay, 80%. That's a solid majority.
Yeah. They experience the pain, they're admitted to the hospital, they receive IV fluids and supportive care, and their pancreas essentially just calms down.
So they go home relatively quickly.
Usually discharged within just a few days, and without any lasting structural damage. If we look at the overall mortality rate across all cases of acute pancreatitis, it ranges from about 1 to 2%.
But there is a massive however lurking right behind that statistic in the sources.
A very critical however. That 1 to 2% is just an average. If a patient's disease progresses to the point where they develop pancreatic necrosis,
Which means the tissue is dying.
exactly, it loses its blood supply and starts to die. Or if they experience systemic organ failure where their lungs or kidneys begin to shut down, that mortality rate spikes dramatically.
So it's not 1 or 2% anymore.
Not even close. The risk of death becomes highly significant once you hit that severe category.
And when we look at who is typically hit the hardest by this, the data points to a very specific demographic window. The peak incidence occurs during the 5th and 6th decades of life.
Right, so people in their 40s and 50s.
But the risk of actually dying from it climbs even higher as patients get older. Why is age such a massive vulnerability here?
It really comes down to a concept we call physiologic reserve.
Physiologic reserve.
Okay, what's that? Think of it as your body's internal shock absorbers. When you're 20, your shock absorbers are brand new.
Right, you can take a hit.
Exactly. If your body sustains a massive inflammatory trauma like a rogue pancreas dumping chemicals into your bloodstream, your heart can pump harder, your lungs can compensate, your kidneys can filter the debris, you bounce back.
But as we age, those shock absorbers wear down.
They do. An older adult naturally has less baseline resilience. Furthermore, they frequently have pre-existing comorbid conditions.
Like what? High blood pressure.
High blood pressure, mild heart disease, some chronic kidney disease. When the pancreas triggers this massive systemic vascular crisis, an older body simply has a much harder time buffering that trauma.
Because the organs are already working closer to their maximum capacity.
Exactly, so they fail much faster under the stress of systemic inflammation. Plus, older patients sometimes present with atypical symptoms, which can lead to a dangerous delay in getting the actual diagnosis.
That makes a lot of sense. Now let's look at what actually causes this in the first place, because the demographic divides here in the sources are really fascinating.
They really paint the picture of two different diseases, in a way.
Right. The epidemiologic data breaks cases down based on etiology, the root cause. And it seems like the two absolute biggest culprits, by a wide margin, are gallstones and chronic alcohol use.
Ain't top two, by far.
But they don't affect everyone equally, do they?
No, they don't. The data shows distinct demographic clustering. Alcohol-related acute pancreatitis tends to be much more common in lower-income populations.
And why is that? Is it strictly about just the volume of alcohol consumed?
It's multifactorial. It reflects larger systemic issues related to socioeconomic status. Lower-income populations often experience higher levels of chronic stress.
Which is a known driver of substance use disorders.
Exactly, including heavy alcohol consumption. Furthermore, there's often less access to preventative health care, addiction support services, nutritional counseling. It's a compounding systemic vulnerability.
Okay, and then on the flip side, we have gallstone-related pancreatitis. The data says this is more frequently seen in older adults, and specifically in populations with higher rates of obesity and metabolic syndrome.
Right. And this ties directly back to our earlier discussion about the rising incidence. Gallstones are intimately linked to metabolic health.
Also, what actually forms a gallstone?
They form when the cholesterol or bilirubin in your bile becomes supersaturated and crystallizes. Obesity, rapid weight loss, diets high in refined carbs and saturated fats. All of that alters the composition of your bile,
Making it sludgy, basically.
making gallstones much more likely to form. Since metabolic syndrome and obesity are increasing across the board, the pool of people developing gallstones is expanding, which directly fuels the rise in gallstone-induced pancreatitis.
Now, I want to pause right here because I noticed a glaring paradox in the clinical data, and I really want to challenge it.
Okay, let's hear it.
We just established that hospitalizations are rising. We know that the underlying risk factors, obesity, metabolic syndrome, high triglycerides, are getting worse across the population.
Right.
So if the triggers are increasing and more people are ending up in the hospital, Why do the clinical reports state that the overall mortality rate for acute pancreatitis is actually declining?
It seems backwards, right?
Exactly. How can it be getting more common but less deadly at the same time?
It is a brilliant observation, and it highlights one of the major triumphs in modern medical management over the last few decades. The why behind that declining mortality rate is that the medical field has become exceptionally skilled at catching the falling knife.
Catching the falling knife. I like that. What does that mean in this context?
Well, we aren't necessarily stopping the initial trigger, right? People are still developing gallstones, people are still drinking heavily, the fire is still starting, but we have fundamentally changed how we respond to the fire.
So the ER doctors are just faster.
Faster and smarter. In the past, doctors might have waited to see how bad the symptoms got before intervening aggressively. Today, we don't wait. The mortality is declining because of significantly improved supportive care, earlier recognition, and crucially, the widespread implementation of standardized severity assessment tools.
What kind of tools? Are we talking about specific blood tests?
Blood tests are a big part of it, but I'm talking about comprehensive scoring systems. The literature specifically points to the revised Atlanta classification and the BISAP score.
BISASEP, what does that stand for?
Bedside Index for Severity in Acute Pancreatitis.
So if I'm wheeled into the emergency room, the doctors aren't just looking at me and guessing how sick I am based on how much I'm groaning. They're running me through a specific algorithm.
Exactly. And these aren't just bureaucratic checkboxes for the hospital administration. They are highly refined, statistically validated clinical protocols.
How do they work, practically speaking?
They allow a physician to look at a patient the moment they come through the doors, take a few vital signs, draw some basic labs, and immediately stratify their risk.
Like predicting who's going to crash.
Yes. The BISAP score, for example, looks at 5 simple parameters in the first 24 hours. Things like blood urea nitrogen levels, impaired mental status, systemic inflammatory response syndrome, or SIRS age over 60, and pleural effusion.
Pleural effusion, that's a fluid around the lungs, right?
Correct. And based on those 5 things,
They can basically see the future.
they can predict with remarkable accuracy who is going to have that mild self-limiting case and who is about to fall off a physiological cliff.
And once they know that, they can intervene.
By identifying the high-risk patients on day 1, doctors can allocate aggressive ICU care, pump in massive amounts of intravenous fluids to support the cardiovascular system, and monitor organ function long before the organs actually start failing.
We're putting the fire out before the whole neighborhood burns down.
Exactly.
That is incredible. But if we want to follow that analogy, we really need to understand how the fire starts in the first place.
Right, the pathogenesis.
Yeah. We know the macro level triggers a rogue gallstone blocking a duct or years of heavy alcohol use. But how does a physical stone or a liquid like alcohol translate into a physical organ completely destroying itself?
We have to zoom in for that.
Right. To understand that, I want to take the listener on a journey. We have to zoom all the way in, down past the organ, past the tissue, right into the microscopic cells of the pancreas.
That is exactly where the true pathogenesis lies. And what we find when we zoom in on the pathophysiology is this complex, almost tragic cascade that begins with a single catastrophic cellular error.
Okay, lay it on us.
The central initiating event of all acute pancreatitis, regardless of whether it was caused by a gallstone or alcohol, is the premature activation of digestive enzymes inside the pancreatic acinar cells.
Okay, let's establish the geography here. The acinar cells. If the pancreas is our biological munitions factory, the acinar cells are the actual assembly line workers, right?
That is a perfect way to visualize it.
Because their entire job is to manufacture these explosive digestive enzymes.
Yes. The acinar cells make up the bulk of the pancreatic tissue, and under normal, healthy physiologic conditions, they operate with incredible safety protocols. These enzymes are synthesized as inactive precursors. We call them zymogens.
Zymogens, okay.
Oh.
So they are essentially enzymes that are locked in an off position.
Correct. Think of a zymogen as a highly destructive tool that has a protective molecular cap securely fastened over its active site.
Like a safety pin on a grenade.
Exactly like that. While that cap is on, it is harmless. The acinar cell manufactures these zymogens, packages them safely into tiny transport vesicles, and secretes them out of the cell into the pancreatic ductal system.
And where do they go from there?
They travel down the pancreatic duct, completely inactive, until they reach the duodenum, which is the very first section of your small intestine.
And the small intestine is where the food is waiting.
Exactly. Once they're safely inside the intestine, and only then an enzyme on the intestinal wall called enterokinase cleaves off that protective cap.
It pulls the pin.
It pulls the pin. The zymogen is converted into its active form, and it goes to work breaking down the proteins, fats, and carbohydrates in your meal. It is a brilliant system. The chemicals that dissolve meat are only armed once they are safely inside a tube designed to handle them.
But in acute pancreatitis, something triggers that on switch way too early. The safety protocols just fail.
Tragically, yes.
And reading through the pathophysiology reports, there is one specific enzyme that acts as the absolute ringleader of this destruction. It's called trypsin.
Trypsin is the critical spark. It is the match that lights the powder keg. In the pathology of this disease, the inactive precursor, which is called trypsinogen, is inappropriately converted into active trypsin while it is still sitting inside the acinar cell.
So the cap gets pulled off while it's still on the assembly line.
Yeah.
Why is that so dangerous? I mean, is trypsin really that powerful?
It's not just that trypsin itself is powerful, though it aggressively breaks down proteins. It's that trypsin acts as the master switch for all the other enzymes.
Oh, no.
Yeah. Once trypsin is activated inside the cell, it initiates a massive proteolytic cascade. It basically runs down the assembly line, ripping the protective caps off of all the other thymogens.
Farming everything in sight.
Exactly. It activates elastase, which destroys elastic fibers in blood vessels. It activates phospholipase, which destroys cell membranes.
So to go back to our munitions factory analogy,
Yeah.
the pancreas is manufacturing these bombs.
Mm-hmm.
Normally, they're shipped in safe, deactivated crates, transported all the way to the battlefield of the intestines, and only armed on the front lines. But high pressure from a gallstone, or chemical stress from alcohol, causes someone to arm the master bomb while it's still sitting deep inside the factory. And when that one goes off, it sets off every other bomb in the building.
That is exactly what happens. But we have to ask what actually causes that premature arming sequence. What goes wrong in the cell to make trypsinogen activate?
Right. What's the actual mechanism?
The literature identifies a sequence of severe intracellular disturbances. Let's look at a gallstone, for example. If a gallstone physically blocks the main exit duct of the pancreas, the newly manufactured enzymes have nowhere to go.
So they just start backing up.
Yes. The intraductal pressure skyrockets, and this high pressure causes a backflow that fundamentally disrupts the fragile internal environment of the acinar cell.
The cell is basically getting crushed from the inside out.
Yes, and that mechanical stress triggers chemical chaos. The normal calcium signaling within the cell goes completely haywire.
Calcium, like what does that do?
Calcium levels inside the cellular fluid spike to toxic levels. This leads to intracellular acidosis. The environment inside the cell becomes highly acidic.
That sounds bad.
It is. The mitochondria, which are the power plants of the cell, begin to dysfunction. And because the mitochondria are failing, the cell experiences a massive depletion of ATP, which is its fundamental energy source.
So if I'm picturing this right, the exit doors are blocked, the pressure is building, the cell is suffocating, it's losing its energy, the fluid inside it is turning into acid, and its internal communication system is short-circuiting all at the exact same time.
Precisely. The cell is in total distress. And all of these compounding insults impair the cell's internal trafficking system. The vesicles that carry the zymogens get stranded.
They're stuck in traffic.
Exactly. But the ultimate critical failure, the exact moment the bomb is truly armed, happens when the integrity of a specific internal structure called the lysosomal membrane is compromised.
Okay, what is a lysosome?
You can think of a lysosome as the cell's internal recycling center, or a garbage disposal. It's a tiny membrane-bound sac that contains its own set of extremely potent, highly acidic enzymes called hydrolases.
Okay, so another dangerous bag of chemicals.
Right. Under normal conditions, zymogens and lysosomes are kept strictly separated. But because the cell is suffocating and the calcium signaling is chaotic, the normal transport pathways collapse. The vesicles carrying the inactive zymogens literally crash into the lysosomes. The membranes fuse.
Oh, man. So they mix together.
We call this colocalization. The inactive zymogens and the highly acidic lysosomal hydrolases are suddenly forced to occupy the exact same microscopic space.
And that's the spark.
That highly acidic environment, combined with the lysosomal enzyme cathepsin B, is the perfect chemical trigger to cleave the cap off trypsinogen. Colocalization is the essential final step. Trypsin is activated, the cascade begins, the factory is now on fire.
And because these enzymes are explicitly designed by evolution to break down human tissue, I mean, to digest the meat and fat in our diet, They don't care that they're still inside the pancreas.
They don't know the difference.
They just start digesting the organ itself. The reports call it autodigestion. The organ is literally eating itself alive.
It's a terrifying biological reality
Ugh.
that autodigestion destroys the pancreatic parenchyma, which is the functional tissue of the organ, and it destroys the protective fat layer surrounding the pancreas. The structural integrity of the organ is rapidly shredded by its own creations.
Okay, which brings us to a really critical pivot point in our understanding of this disease.
How it spreads.
Right. The bombs have gone off, the local tissue is melting. But how do we get from a localized explosion in this one specific organ sitting behind the stomach to a body-wide, life-threatening emergency?
It's the most important question.
Yeah, because why do the lungs fail? Why do the kidneys fail? If digestive enzymes are trapped in the pancreas, how does this turn into systemic shock?
And the answer is that it's actually not the digestive enzymes that directly attack the other organs. It all comes down to the chemical debris left behind by the explosion.
The debris.
Yes. When that pancreatic tissue and the peripancreatic fat are destroyed by autodigestion, the dead and dying cells literally burst open. And as they rupture, they release massive amounts of what immunologists call DAMPs.
DAMPs. DAMPS. I saw that acronym in the research. What exactly is a DAMP? Is it like a biological flare gun?
A biological flare gun is a brilliant way to describe it, honestly. DAMPs stands for damage-associated molecular patterns.
Oh.
They are internal molecular signals. Usually they're hidden safely inside the cell.
When the cell bursts.
Exactly. When a cell suffers traumatic, unnatural death, like being digested alive, those molecules spill out into the surrounding tissue fluid. When the body's immune system detects DAMPs, it reads them as a catastrophic distress signal.
So it's screaming for help.
It screams to the immune system, "We have suffered massive tissue damage. Send the cavalry immediately."
And the immune system responds.
It over-responds. This initiates an incredibly robust, overwhelming inflammatory cascade. The local immune cells flood the area with cytokines, which are potent inflammatory chemical messengers.
And what do the cytokines do?
These cytokines act as a homing beacon. They recruit vast armies of white blood cells, specifically neutrophils and monocytes, from the bloodstream directly to the site of the injury in the pancreas.
So the body is trying to help. It's sending in the first responders to clean up the dead tissue.
That's the intent, yes.
But from what I read, the immune system's response is so aggressive, so utterly disproportionate, that the first responders actually end up causing secondary damage.
Yeah, the sheer volume of inflammatory cytokines being released is too much for the local area to contain. The inflammation doesn't just stay in the pancreas, it spills over directly into the systemic bloodstream.
And that's when it hits the rest of the body.
And this is where the true life-threatening danger begins. When these concentrated cytokines hit the systemic circulation, they cause widespread endothelial injury.
The endothelium.
Yeah.
That's the lining of the blood vessels, right?
Correct. It is the delicate microscopic inner lining of every single blood vessel in your body. When the endothelium is injured by these cytokines, the blood vessels experience increased vascular permeability.
Meaning what exactly?
They literally become leaky, the tight junctions between the cells open up, suddenly the fluid portion of your blood, the plasma, starts leaking out of your veins and arteries and pooling into the surrounding tissues.
Oh man, that sounds disastrous for blood pressure.
It is. Your cardiovascular system starts losing its volume rapidly. But the cytokines do something else too. They activate the coagulation cascade inappropriately.
Coagulation, so blood clots.
Yes. This triggers microvascular thrombosis, meaning tiny microscopic blood clots start forming in the capillaries all over your body.
So you have blood vessels that are leaking all their fluid out, and whatever sluggish blood is left is getting blocked by thousands of tiny clots.
Exactly. This widespread inflammatory chaos is clinically defined as SIRS, systemic inflammatory response syndrome. If SIRS is not reversed, it quickly leads to MODS, multiple organ dysfunction syndrome.
So this is why the other organs fail.
This explains the exact mechanics of the systemic crisis. The patient's lungs don't fail because the pancreas attacks them. They fail because the systemic vascular alarm makes the capillaries in the lungs so leaky that the lungs literally fill with fluid.
Acute respiratory distress syndrome, right?
Exactly. And the kidneys shut down because the microvascular clots and the massive loss of blood pressure starve them of the oxygenated blood they need to filter toxins. It is a profound systemic cardiovascular shock driven entirely by local trauma.
To really visualize the sheer scale of this trauma, the pathology reports break down the histopathology, which is what the pancreatic tissue actually looks like if you put it under a microscope.
Right, the visual evidence.
And they divide it into two main categories depending on how bad the autodigestion is. The first category is called interstitial edematous pancreatitis.
This represents that 80% of mild cases we discussed earlier. Histologically, if you look at a slide of this tissue, you'll see edema, which is fluid swelling separating the lobules of the pancreatic tissue.
Just a lot of fluid.
Yeah. You will see those immune cells, the neutrophils, scattered around the area. But crucially, the overall architecture of the acinar cells remains mostly intact.
So the building is still standing.
Yes. The fat necrosis is very minimal. If a surgeon were to look at the organ grossly in the operating room, it just appears swollen, pale, and boggy. It's highly inflamed, but the tissue is not dead. This process is generally self-limited. The immune system calms down, the swelling subsides, and the organ resolves.
The second category is where things take a very, very dark turn. Necrotizing pancreatitis.
This is the severe form.
The description in the literature here is intense. It mentions widespread parenchymal destruction, massive hemorrhage, and the tissue grossly appearing dark red to black and friable.
Friable meaning it easily crumbles or tears apart if you just touch it.
Which is horrifying. But there's one specific word in the histopathology report that I really want you to explain for the listener because it stopped me in my tracks.
Oh, I think I know which one.
Saponification. The text says there is extensive fat necrosis with saponification. Are we literally saying that the fat inside the human body is turning into soap?
In a very literal chemical sense, yes. We are talking about the biological creation of soap inside the abdomen.
Wait, hold on. Let's pause right here. You are telling me the fat inside my abdomen turns into actual literal soap. How is that even possible?
Think about how humans have made soap artificially for thousands of years. You take an animal fat or a plant oil and you combine it with a strong alkali like lye. A chemical reaction occurs that turns the fat into soap.
Right, basic chemistry.
In the human body, during severe necrotizing pancreatitis, a very similar chemical reaction takes place. We talked about how those powerful digestive enzymes escape the pancreas. One of those activated enzymes is lipase, whose sole job is to break down fats.
Right, it's supposed to be breaking down the fat in my cheeseburger.
Exactly, but instead massive quantities of active lipase escape into the peripancreatic fat that's the thick layer of adipose tissue that cushions the organs in your abdomen.
Okay.
The lipase relentlessly attacks this fat, cleaving the triglyceride molecules into free fatty acids. Now you have a pool of highly reactive free fatty acids floating in the tissue fluid.
And then what happens?
At the same time, you have calcium naturally circulating in that fluid. Those free fatty acids chemically bind or chelate with the calcium.
And fat binding with calcium creates soap?
It creates calcium soaps. The peripancreatic fat undergoes biological saponification. If you were to look at it during surgery, you wouldn't see normal, yellow, squishy body fat. You would see hard, chalky, opaque, white deposits scattered all over the dead tissue.
That is just mind-blowing and horrifying. I can't imagine what that does to the body's overall calcium levels if it's all being sucked up to make soap in the abdomen.
That is actually a brilliant clinical insight. In severe necrotizing pancreatitis, the saponification process consumes so much circulating calcium that the patient can develop profound hypocalcemia, dangerously low blood calcium levels.
Which causes its own problems, I assume.
Oh, absolutely. It can cause muscle spasms and dangerous cardiac arrhythmias. It's just another way the local explosion wreaks havoc on the systemic balance.
Now, for most people who go through this nightmare, even if it's just the milder edematous form, this factory explosion is a singular, highly traumatic event.
Right, an isolated incident.
They get treated, they recover, maybe they get their gallbladder removed, or they stop drinking, and hopefully it never happens again. But looking at the epidemiologic data, there is a recurrence rate ranging from 0.6% to 5.6%.
Yes.
For a specific subset of people, the factory just keeps spontaneously catching fire over and over again, seemingly out of nowhere. Why does that happen?
Well, while the highest absolute numbers of recurrence are typically seen in patients who simply cannot stop chronic heavy alcohol use, there's another highly distinct group where the recurrence is driven entirely by their biology.
By their genes.
Yes. Genetic susceptibility plays a massive driving role in early onset or recurrent cases of acute pancreatitis. For these individuals, their genetic code has inherently weakened the safety mechanisms of the acinar cell.
So they don't even need a trigger.
Exactly. They don't need a gallstone or alcohol to start the fire. Their factory is built with faulty wiring from day one.
The pathophysiology reports list 4 specific genetic mutations that create this dangerous loop. I want to walk through them because it really highlights the different, highly specific ways the cellular system can break down.
Let's do it.
Let's start with the first one,
Okay.
a mutation in the PRSS1 gene. What does that do?
The PRSS1 gene is the blueprint that tells the acinar cell how to build cationic trypsinogen, which remember is the inactive precursor to our ringleader enzyme, trypsin. The mutation here is what geneticists call a gain-of-function mutation. It essentially makes the trypsinogen far too eager to activate. It lowers the threshold required to pull that protective cap off.
So it's hypersensitive.
Extremely. Furthermore, it alters the structure of the enzyme so that the body cannot properly break down the trypsin once it is active. The result is excessive, unchecked trypsin activity inside the cell.
Okay, let's use a car engine analogy here to make this mechanical. If the acinar cell is a car engine, the PRSS1 mutation is like a stuck accelerator pedal. The engine is just endlessly revving, producing way too much active trypsin, and you can't lift your foot off the gas.
That is exactly right. The baseline level of danger is permanently elevated. Now, contrast that with the second major mutation, which involves the SPNK1 gene.
SPNK1. That stands for serine protease inhibitor Kazal type 1.
That's a mouthful, I know.
What does it actually do?
Its entire job is to act as an intracellular failsafe. In a normal, healthy person, if a tiny amount of trypsin accidentally activates prematurely inside the cell, which happens occasionally, the SPNK1 protein immediately binds to it and shuts it down before it can trigger the proteolytic cascade.
So it's like a molecular fire extinguisher.
Perfectly said. But a mutation in the SPNK1 gene impairs the production or function of that inhibitor.
So sticking with our car analogy,
Yeah.
if PRSS1 is a stuck accelerator pedal, SPNK1 is like someone snuck in during the night and completely cut the brake lines.
Yeah.
The safety inhibitor is gone. Even a normal, everyday amount of engine revving is now incredibly dangerous because if the car starts rolling, there are no brakes to stop it.
That's a perfect visualization. The third mutation mentioned in the literature is in the CTRC gene, which encodes for an enzyme called chymotrypsin C.
And what's its role?
Normally, CTRC acts as a secondary cleanup safeguard by degrading and clearing out active trypsin that escapes SPNK1. A mutation here interferes with that degradation process. The cleanup crew is on strike.
Which means the trypsin just hangs around.
Exactly. It hangs around much longer than it should, continuing to cause damage.
The final genetic vulnerability mentioned is CFTR, the cystic fibrosis transmembrane conductance regulator. Now, most people know CFTR because of its role in cystic fibrosis in the lungs.
Right.
This one seems a bit different. It doesn't directly deal with trypsin or safety inhibitors.
It doesn't interact with trypsin directly, but its role in the pancreas is equally critical. The CFTR protein acts as a channel on the surface of the ductal cells. It's responsible for secreting bicarbonate and fluid into the pancreatic ducts.
Like a wash system.
Yes. This steady flow of watery fluid is what literally washes the newly manufactured digestive enzymes out of the pancreas and flushes them down into the intestine. A mutation in CFTR disrupts this fluid secretion.
I see, so the fluid becomes thick.
Exactly. The pancreatic secretions become incredibly thick, viscous, and sluggish, severely impairing ductal clearance. This leads to microscopic blockages, increased intraductal pressure, and eventually the premature activation of those trapped enzymes.
To finish our car analogy, the CFTR mutation is like the exhaust pipe getting completely plugged with sludge. The engine backs up, overheats, and eventually blows a gasket.
Brilliant analogy.
Now, what is the long-term reality for a patient living with these genetic alterations? The sources indicate it doesn't just stay as occasional acute attacks.
That is the tragic, long-term reality of these genetic loops. These mutations fundamentally strip away the host's physiologic capacity to contain inflammation.
So it just wears the organ down.
Yes. What begins in childhood or early adulthood as recurrent, excruciating acute injuries eventually progresses to a disease state called chronic pancreatitis.
How is chronic different from acute, functionally?
Acute disease, as we discussed, is characterized by sudden swelling, perhaps necrosis, but an eventual resolution. Chronic pancreatitis is a state of permanent, irreversible structural decline.
So the damage never heals.
Never. The repeated fires happening over years and years lead to massive fibrosis, dense scarring of the delicate pancreatic tissue. The functional acinar cells literally atrophy and die off, replaced by useless scar tissue and calcified stones.
And when the organ turns to scar tissue, it obviously stops doing its job.
Precisely. Eventually, the patient develops profound endocrine and exocrine insufficiency. Because the pancreas is destroyed, it can no longer produce enough insulin to regulate blood sugar, leading to a brittle, difficult-to-manage form of diabetes.
And the digestion part.
It can no longer produce those digestive enzymes at all. This leads to severe maldigestion, chronic diarrhea, and profound malnutrition. They literally cannot absorb the nutrients from the food they eat.
It's a profound transition from an intermittent acute emergency to a daily, life-altering chronic condition.
It really is. It changes their entire life.
That is a heavy reality to carry. Well, we've deeply explored the cellular biology, the systemic inflammatory cascades, and the underlying genetics that dictate who gets caught in this.
We've covered the why and the how.
Exactly. Now, let's shift our perspective. Let's step out of the textbook and put ourselves right in the middle of a chaotic emergency room. A patient walks through the doors. We know what's happening to their cells, but what do they actually feel? And how does the physician, who can't see their cells, begin to piece this complex puzzle together?
The clinical presentation of acute pancreatitis is usually quite dramatic. It's hard to ignore. The absolute hallmark symptom is moderate to severe epigastric abdominal pain.
Epigastric, so that's right in the upper middle of the abdomen.
Yes, just below the rib cage. Patients often describe it as a deep, burning, or relentless stabbing sensation. And crucially, because the pancreas is a retroperitoneal organ.
Meaning it sits very far back in the abdominal cavity.
Right, it's plastered up against the muscles of the spine behind the stomach. Because of that location, this intense pain very frequently radiates directly through to the patient's back.
I was reading the clinical diagnostic protocols, and they mentioned that the specific way the pain starts can actually give doctors their very first major clue about the underlying cause.
Yes, the onset trajectory is highly informative. A sudden, sharp, explosive onset of maximum pain where the patient is fine 1 minute and doubled over in agony the next is highly suggestive of a gallstone etiology.
Because it's a mechanical blockage.
Exactly. The stone drops out of the gallbladder, wedges into the biliary duct, and the intraductal pressure spikes instantly. Conversely, alcohol-induced pancreatitis often presents with a more gradual, insidious onset of pain.
It creeps up on them.
It might be dull and poorly localized initially, slowly building in intensity over several days following a prolonged period of heavy drinking, as the chemical toxicity slowly damages the acinar cells.
Alongside that agonizing pain, the patient is usually dealing with severe, intractable nausea, repeated vomiting that doesn't relieve the pain, and a complete loss of appetite. When the medical team gets them into a bed and takes their vital signs, what are they seeing on the monitors?
They are looking for the immediate systemic echoes of that inflammatory damp cascade we discussed earlier. They will almost always see tachycardia, a rapid heart rate of over 100 beats per minute, and often a fever.
Driven by those cytokines.
Driven by the massive release of cytokines like interleukin-6 and TNF-alpha into the bloodstream. But the vital sign the attending physician is watching most closely, with the most anxiety, is the blood pressure.
Looking for hypotension.
Exactly. Hypotension, or abnormally low blood pressure, is a massive red flag. It indicates that the vascular permeability, the capillary leak we talked about, has begun in earnest.
The fluid is leaking out.
The fluid is leaking out of the blood vessels and into the surrounding tissues, a process we call third spacing. The cardiovascular system is rapidly losing its operating volume, which is the immediate precursor to systemic hypovolemic shock. If the pressure drops too low, the organs die.
Wow. When the physician actually steps up to the bed and physically examines the patient's abdomen, they're looking for epigastric tenderness and guarding. Guarding is where the abdominal muscles involuntarily tense up, right? Becoming rigid to protect the highly inflamed organ beneath them.
That's right.
But here's where it gets really interesting to me. I was looking through the physical exam notes, and the clinical protocols mention two very specific, very famous visual clues that a doctor might find directly on the patient's skin: the Cullen sign and the Gray-Turner sign.
Yes. These are classic eponymous signs taught to every medical student. They are somewhat rare to actually see in practice, but when you do see them, they indicate severe hemorrhagic necrotizing pancreatitis.
What do they look like?
The Cullen sign presents as a faint bluish-purple discoloration ecchymosis, essentially a bruise circling the umbilicus or the belly button. The Gray-Turner sign is a similar bruising pattern, but it's located on the patient's flanks, along the sides of the abdomen between the last rib and the top of the hip.
I want to make sure I understand the mechanics of this because it's wild. It's like blood seeping under a locked door, right?
That's a good way to picture it.
Because the pancreas is buried deep, deep inside the retroperitoneal space at the back of the abdomen. It is nowhere near the skin of the belly button.
Not at all.
But it is bleeding so profusely from the autodigestion and necrosis that the blood literally tracks its way along the fascial planes of the internal abdominal wall muscles, creeping forward until it pools just under the skin of the belly button or the flanks.
Yeah.
It gives the doctor this terrifying, undeniable visual confirmation of a massive hemorrhage happening completely out of sight.
That is exactly how it happens. The blood dissects through the anatomical planes. It is a powerful, ominous visual indicator of just how destructive the disease process has become.
It's chilling.
But long before a physician starts looking for rare bruises, their most vital foundational diagnostic tool isn't a physical exam or a scanner. It is the patient history.
The detective work.
Precisely. A meticulous, detailed clinical history is absolutely critical, not just for confirming the diagnosis of pancreatitis, but for identifying the specific etiology. Because if you don't find the trigger, you can't stop the cascade.
If I'm the patient, what is the doctor asking me while I'm laying there in pain? The sources have a very specific checklist. I imagine they were looking for a history of chronic heavy alcohol use.
They are.
And the text defines this fairly strictly as 4 to 5 drinks daily for more than 5 consecutive years. They're also asking about a history of gallbladder disease, right? Known gallstones or prior episodes of biliary colic that sharp pain after eating a fatty meal.
They are definitely probing for those two big ones. But a thorough physician has to dig deeper. They have to ask about recent medical procedures. For example, has the patient recently had an ERCP?
What is an ERCP?
It stands for endoscopic retrograde cholangiopancreatography. It's a specialized, highly invasive endoscopic procedure where a gastroenterologist threads a camera down the throat, past the stomach into the duodenum, and then cannulates the tiny opening of the bile and pancreatic ducts.
Sounds intense.
They inject contrast dye under pressure to take x-rays of the ductal system. It is incredibly useful for finding and removing trapped gallstones.
But there's a catch.
A big one. The physical act of mechanically irritating the delicate sphincter or injecting dye under high pressure directly into the pancreas can actually inadvertently cause acute pancreatitis. It is a known, significant iatrogenic risk.
So the test used to fix the bile ducts can actually trigger the pancreas to self-destruct. What else are they looking for in the history?
A comprehensive medication review is vital. There are dozens of specific drugs known to occasionally trigger the disease, immunosuppressants like azathioprine, anti-seizure medications like valproic acid, and even incredibly common blood pressure medications like ACE inhibitors or diuretics.
They really need to know everything.
The doctor has to know everything the patient swallowed in the last week.
They also ask about smoking, which I noticed is listed as an independent risk factor separate from alcohol. And tying back to our earlier discussion, family history is crucial. If the patient is young, say under 30, and they don't drink and don't have gallstones,
the doctor immediately has to suspect those genetic loops, the PRSS1 or SPINK1 mutations. What is vital to understand here is the immense, irreplaceable value of this detailed conversation. In modern emergency medicine, there is often an overwhelming temptation to simply wheel a patient in pain immediately to a high-tech CT scanner to get a picture.
just skip the talking and scan them.
Right. But a thorough history gives the physician context that no scan can ever provide. A CT scan can show you a swollen pancreas. But the history tells you if this is a first-time acute event driven by a new gallstone that needs immediate removal, or an acute on chronic exacerbation driven by years of alcohol use.
That context dictates the entire trajectory of care,
Completely.
which perfectly transitions us to the actual diagnostic process. The patient is in agony, the visual clues might be there, the exhaustive history is taken. How does the medical team definitively, scientifically lock in the diagnosis? Because they can't needlessly cut the patient open to look at the pancreas, and they can't run every single blood test in the hospital.
No, they can't.
How do they know for sure?
They rely on a highly standardized, universally accepted diagnostic framework called the Revised Atlanta Classification. It establishes a simple, elegant 2 out of 3 rule for diagnosing acute pancreatitis.
2 out of 3 rule.
Okay. To confirm the diagnosis, the patient must meet at least 2 of the following 3 criteria. Number 1. Characteristic abdominal pain, that deep, acute onset epigastric pain radiating to the back that we discussed.
Sure.
Number 2, serum amylase or lipase levels that are 3 or more times the upper limit of normal. And number 3, imaging findings consistent with acute pancreatitis on a CT scan, MRI, or ultrasound.
Okay, let's focus on criterion number 2 for a second, the blood work. Amylase and lipase are those digestive enzymes the acinar cells manufacture. They're supposed to be inside the digestive tract.
Yes.
If a blood test shows they are floating in the systemic bloodstream at levels 3 times higher than normal, it is definitive chemical proof that the factory has exploded and the enzymes are leaking out.
Exactly. The elevated lipase is the biochemical footprint of autodigestion. And because the clinical presentation of the pain combined with those elevated pancreatic enzymes is so highly reliable, those first 2 criteria are usually completely sufficient to establish the definitive diagnosis on their own.
Wait, really?
Yes, you don't need the third criterion.
Now wait, stop right there.
Yeah.
This is where I have to push back a bit based on everything we've discussed so far.
Wait.
If we established earlier that the pancreas could literally be turning to necrotic plaque mush, if there could be massive hemorrhage tracking along the fascial planes, if the fat could be undergoing literal saponification turning into soap,
Yes, all those terrible things.
why wouldn't a CT scan be the absolute first thing you do for every single patient?
Yeah.
Why is imaging relegated to being the third, potentially optional criterion? If I'm the patient, put me in the tube and see how bad the fire is.
It is a very natural reaction. It seems entirely counterintuitive to wait, but this raises an incredibly important point about medical resource management and, more importantly, patient safety.
How is it a safety issue?
The reality is an early CT scan, one done in the first 48 hours of symptoms, is often remarkably unhelpful and potentially highly dangerous.
Dangerous how? It's just an X-ray, right?
A scan itself is an X-ray, but to see the pancreas and the blood vessels clearly, the radiologist has to inject the patient with intravenous contrast dye. Now, remember what is happening to our severe pancreatitis patient.
To losing fluid.
They are profoundly hypovolemic. Their blood vessels are leaking, their third spacing fluid, their blood pressure is dropping, and their kidneys are already under immense physiological stress from the microvascular thrombosis and the lack of blood flow.
The kidneys are starving for oxygen.
Yes. The contrast dye used in CT scans is notoriously nephrotoxic, meaning it is hard on the kidneys. It requires healthy kidneys to filter it out.
Oh, I see where this is going.
Injecting a heavy load of chemical contrast dye into a patient whose kidneys are already struggling to survive the systemic shock can easily push them over the edge into acute, irreversible renal failure. You could save the pancreas, but destroy the kidneys.
Oh, wow. I hadn't thought of that. Do no harm.
Exactly. Furthermore, from a purely diagnostic standpoint, the scan doesn't give you accurate information on day 1.
Why not?
The full extent of ischemic necrosis, the dead tissue, hasn't usually demarcated yet. It takes time for tissue to visibly die on an X-ray. If you scan them on day 1, the pancreas might just look a bit swollen, showing interstitial edema. It gives the physician a false sense of security.
When really there's a fire brewing.
The true massive necrosis might not be visible on a scan until day 3 or 4.
So you risk destroying their kidneys to get a scan that might lie to you and tell you everything is fine, while a massive fire is secretly building.
Precisely. The 2 out of 3 rule is an elegant, evidence-based safeguard. It allows doctors to confidently diagnose the condition and begin treating the patient immediately with aggressive IV fluids and heavy pain control, relying solely on the labs and the exam.
That makes perfect sense.
It dictates that they reserve the risky CT scans for patients who face genuine diagnostic uncertainty, meaning maybe their pain is atypical and they need to rule out a perforated ulcer, or for patients whose clinical course dramatically worsens after 72 hours, at which point the necrosis will be clearly visible and the kidneys have hopefully been stabilized by the IV fluids.
Rely on the clinical signs and the lab work first. And speaking of lab work, while the doctor is waiting to see how the patient does, they are running other tests to find the etiology. I read about one specific blood test that acts like a magic bullet for finding gallstones.
The ALT test.
Right. The protocols state that an alanine aminotransferase, or ALT, level greater than 150 units per liter within the first 48 hours has a greater than 85% positive predictive value for gallstone pancreatitis.
It is an incredibly powerful, highly specific metric. ALT is not a pancreatic enzyme. It is a liver enzyme.
So why does it spike?
If a gallstone drops out of the gallbladder, it travels down the common bile duct. The bile duct and the pancreatic duct join together right before they enter the intestine. If a stone lodges at that junction, it blocks both ducts.
Ah, so the liver gets squeezed too.
Yes. It causes back pressure into the pancreas, causing the pancreatitis, but it also causes back pressure up into the liver. This transient liver stress causes the liver cells to release ALT into the blood.
That's a clever way to figure it out.
It is. Therefore, if you see that single number, an ALT, over 150, it tells the physician with 85% certainty that a gallstone is the culprit. That immediately dictates that the patient needs a safe, non-invasive ultrasound of the right upper quadrant to definitively find the stone.
And what other labs are they running?
The doctors will also run other labs, of course. They will check serum calcium and triglycerides to look for the metabolic triggers we discussed, and they might check IgG4 antibody levels if they suspect a rare autoimmune cause. But that ALT number is a vital, immediate clue.
Okay, so the diagnosis is locked in. The etiology is suspected, whether it's alcohol, a stone, or high triglycerides. But as we learned right at the beginning, this disease is a vast spectrum.
It ranges wildly.
It ranges from a 3-day hospital stay with some IV fluids to fatal multi-organ failure in the ICU. How do doctors look into the future? How do they predict which path the patient in front of them is currently walking down?
They have to track the severity of the systemic inflammatory response in real time. We mentioned the scoring systems like the BISAP score and the Ranson criteria, which look at a multitude of lab values and age factors to predict mortality. But at the bedside, hour by hour, the intensive care physicians rely heavily on serial measurements of two very specific, very common blood markers: blood urea nitrogen, or BUN, and hematocrit.
Let me try another analogy here to see if I grasp why these two markers are so important. Tracking BUN and hematocrit feels a bit like checking the oil dipstick in a car engine to see if you have a leak.
I like where this is going.
Hematocrit measures the percentage of your total blood volume that is made up of solid red blood cells.
Yeah.
BUN measures waste products in the blood that the kidneys are supposed to filter out with water. Now, if those two numbers are steadily rising on the lab reports, it means the blood is getting too concentrated. It's getting sludgy.
Yes.
And the only reason it gets sludgy is because the water, the plasma in the blood, is leaking out into the tissues.
The capillary leak, the third spacing.
Exactly. So if the BUN and hematocrit are rising, it means the massive bags of 5E fluid resuscitation the doctors are pumping into the patient's veins aren't working fast enough to keep the tank full. The tank is leaking faster than they can fill it.
That analogy is absolutely brilliant, and it perfectly captures the terrifying clinical reality of managing this disease. A rising BUN or hematocrit is a direct, undeniable indicator of severe intravascular volume depletion. The patient is effectively dehydrating from the inside out because their blood vessels are so incredibly leaky.
Which means the blood is just turning to mud.
The blood becomes viscous sludge. The heart is trying to pump mud. This leads directly to systemic hypoperfusion. The organs simply aren't getting enough oxygenated blood.
Which is why the kidneys and lungs start to fail.
Precisely. Physicians also monitor lactate levels to assess this poor tissue perfusion. High lactate means the cells are starving for oxygen and switching to anaerobic metabolism. The critical window for all of this is the first 24 to 48 hours. Recognizing this hypoperfusion early, watching that dipstick, dictates the intensity of the ICU care.
And based on how the patient responds in that critical 48-hour window, the revised Atlanta classification stratifies the final disease severity into 3 distinct categories.
Yes, it provides a unified language for doctors. Mild acute pancreatitis involves no organ failure and no local complications. These are the patients who go home in a few days.
Okay, that's category 1.
Moderately severe acute pancreatitis involves transient organ failure, meaning maybe their kidneys struggle but recover within 48 hours, or it involves local complications like fluid collections around the pancreas.
And the third category?
Severe acute pancreatitis is defined strictly by the presence of persistent organ failure lasting more than 48 hours. That persistent failure, whether it's the lungs requiring a mechanical ventilator or the kidneys requiring continuous dialysis, is the exact mechanism that drives the mortality rate up to 30 or 40% in that specific subgroup.
Now, while the blood work is crucial for tracking the systemic response, the doctors eventually do have to use imaging to see what is happening locally to the organ, especially if the patient isn't getting better after a few days or if they suspect a gallstone. The diagnostic protocols outline a very specific hierarchy of imaging modalities.
They do, and it is designed entirely around patient safety. Ultrasound of the abdomen is the absolute first-line imaging modality, and it should be performed on virtually all patients with acute pancreatitis.
But wait, ultrasound uses sound waves. Can sound waves see the pancreas clearly? I thought the stomach and intestines are usually in the way.
You are absolutely correct. The pancreas is notoriously difficult to visualize on a standard trans-abdominal ultrasound because the sound waves are blocked by the gas in the overlying stomach and colon.
So why use it?
However, The ultrasound isn't primarily to look at the pancreas. It is to look at the gallbladder and the bile ducts. Ultrasound is cheap, radiation-free, entirely non-invasive, and it is exceptionally good at finding gallstones or biliary sludge. It identifies the triggers safely.
And as we discussed, the CT scan with IV contrast is reserved for later on, typically after 72 hours. At that point, the dead tissue has demarcated, and the scan can accurately map out the extent of the necrosis or find dangerous local complications like infected pseudocysts.
Or walled-off collections of dead tissue that a surgeon might need to drain.
Right. But the protocols also mention MRI, and specifically MRCP magnetic resonance cholangiopancreatography. What is the advantage of using a massive MRI machine over a quick CT scan?
MRI and MRCP are fantastic tools for very specific scenarios. Their primary advantage is that they provide highly detailed, incredibly sharp images of the delicate biliary and pancreatic ductal anatomy without requiring the nephrotoxic iodine-based contrast dye used in CT scans.
So it saves the kidneys.
Exactly. They carry virtually no physiological risk. This makes MRCP the preferred choice for mapping out a suspected ductal blockage in patients who already have acute kidney injury from the pancreatitis or patients who have severe allergies to CT contrast dye.
There's also mention of EUS endoscopic ultrasonography.
Yes, EUS is a fascinating hybrid. A gastroenterologist uses an endoscope that has a tiny, high-frequency ultrasound probe attached to the very tip. They pass it down into the stomach, right up against the wall of the duodenum, placing the probe mere millimeters away from the pancreas and the bile duct.
Get right up close.
It completely bypasses the intestinal gas.
Yeah.
It offers unparalleled, incredible sensitivity for finding microscopic gallstones, what we call microlithiasis, that a standard external ultrasound might completely miss.
But the clinical protocols draw a very hard, incredibly strict line on the procedure we talked about earlier, ERCP, the endoscopic retrograde cholangiopancreatography.
They do, and it is one of the most crucial rules in managing this disease. As we discussed, ERCP involves passing an endoscope, cannulating the ducts, and injecting dye under pressure. It is a highly invasive procedure that carries a significant known risk of causing or violently worsening an existing case of pancreatitis.
Right. It's a known trigger.
Therefore, the absolute governing rule of the protocol is that ERCP must be reserved strictly for therapeutic purposes.
Meaning you only go in if you already know exactly what you're going to fix.
Exactly. If the safe, non-invasive MRCP, or the EUS, definitively confirms that there is a stone heavily lodged in the common bile duct, causing an ongoing obstruction, or causing cholangitis, which is a deadly infection of the bile duct itself, then, and only then, do you perform an ERCP.
To get the stone out.
You use it to physically go in, cut the sphincter open, grab the stone with a tiny basket, and pull it out. It is a life-saving intervention when used correctly, but you never ever use a highly invasive, potentially destructive tool like ERCP simply to take a look around to confirm a diagnosis. The risk simply outweighs the reward.
It all comes back to that central guiding theme of the medical protocols. Do no harm. Manage the resources wisely. Rely on the detailed clinical history. Trust the elegant diagnostic rules like the 2 out of 3 criteria, protect the kidneys, and intervene aggressively with invasive procedures only when the path is completely clear and necessary.
Exactly.
Well, we have covered an immense amount of ground today. We journeyed from the microscopic misfiring of zymogens in a single suffocating acinar cell. Watch that localized chemical explosion trigger an inflammatory damp cascade that spread through the entire systemic bloodstream, causing capillaries to leak and organs to fail, and learned exactly how doctors use patient history, vital signs, and careful blood monitoring to contain the damage and predict the future of the disease.
It really is a remarkable journey from fundamental cellular pathology all the way to bedside critical care management. But as we wrap up our analysis of these sources, I think there's a broader, perhaps more philosophical context we need to consider.
Oh, I'm intrigued.
We noted at the very beginning that the incidence of this disease is rising steadily, and that rise is driven largely by modern lifestyle factors, obesity, the spread of metabolic syndrome, diets that lead to hypertriglyceridemia.
Right.
These modern factors are acting as the primary triggers for this ancient, devastating self-destruct sequence. And looking at the sheer trajectory of these epidemiologic trends, it raises a rather provocative question for us to ponder.
I love a good provocative question.
Lay it on us.
Given that our modern, highly processed, high-fat diets are fundamentally changing the lipid composition of our blood and the cholesterol saturation of our bile, we have to ask,
Right.
Will this environmental pressure eventually force an evolutionary adaptation in how our bodies package and transport these volatile digestive enzymes?
As well.
Will the human acinar cell be forced to evolve a stronger, more resilient lysosomal membrane to withstand the chemical stress of modern hypertriglyceridemia? Or are our internal organs functioning on delicate biological architecture designed hundreds of thousands of years ago for a completely different environment, simply destined to continue failing under the immense chemical weight of our modern lifestyles?
That is a fascinating and slightly terrifying thought to leave on. Are we fundamentally outpacing our own biological safety mechanisms? We will leave that for you, the listener, to mull over the next time you think about the quiet machinery working away inside you. Thank you so much for joining us on this deep dive into the pancreas. As always, keep that curiosity alive, stay well informed, and remember that sometimes the most dramatic, explosive events are happening in the hidden chemical factories right inside of us. Until next time.